Good morning, everyone. Welcome to the first session on day two of the World Sepsis Congress from the Global Sepsis Alliance. So remembering that the meeting is universal sepsis care for newborns, children and women. This session is entitled AMR and Sepsis Strategies in Different Resource Contexts. We have 5 talks today, and we will be starting with Manish Sadarangani. His title is Can Pop AMR, which stands for Canadian Prospective Observational Study of Pediatric AMR Infections. And Manish is the director of the Vaccine Evaluation Centre at the British Columbia Children's Hospital. He is an expert in translational vaccinology, and I'm delighted to hand over to Manish to give the first talk of the session. Manish.
Thanks, Justin, for the introduction, and thanks to the organizers for the invitation to talk to you about this study today. So these are my disclosures. So you may have already seen this or something similar to this previously during this Congress, and essentially it's the global burden of bacterial antimicrobial resistance, showing the number of deaths occurring associated with and attributable to resistance from a number of different pathogens. And I'm going to focus on the 3 pathogens in this orange box here, which are 3 of the top 4, Staphylococcus aureus, Klebsiella pneumoniae, and Streptococcus pneumoniae. So I'm here in Vancouver in Canada. So just to provide those of you around the world with a bit of the context that I'm working in Canada. So this was a report done by the Council of Canadian Academics, which estimated that in 2018, around a quarter of infections that we were seeing were resistant to the general sort of first, second line antibiotics. And if the current trends continue by 2050, this was expected to be up to 40%. You can see in terms of the effects on health and the healthcare system that we're expected to go from almost 5,500 lives lost per year from AMR to almost 14,000, with cost to the healthcare system going from 1.4 billion to 7.6 billion, and a loss of GDP from 2 billion to 21 billion. And cumulatively, between now and 2050, that equates to around 400,000 lost lives, $120 billion worth of hospital costs, and almost $400 billion loss of GDP in Canada. So we're embarking on this study, CAMPOP AMR. So this stands for the Canadian Prospective Observational Study of Pediatric Antimicrobial Resistant Infections. So I'm leading this study and with a number of co-investigators from across the country, which draws from experts across pediatrics, including pediatric critical care, pediatric emergency medicine, general pediatrics, and also expertise on the laboratory side of the study. So the primary objective of this study is to quantify the burden of severe invasive AMR infections in children across 16 pediatric hospitals in Canada, which is all of the tertiary care pediatric hospitals in Canada, and to describe the pathogen-specific epidemiology by age, sex, gender, ethnicity, and other socio-demographic factors. So in addition to the case numbers, we'll be looking at incidence rates, hospitalization rates, disease manifestations, and various outcomes, including severity markers. The secondary objectives are to try and identify both clinical and bacterial risk factors for these infections for selected pathogens. And as I mentioned, the selected pathogens for the purposes of this study are Klebsiella, Streptococcus pneumoniae, and Staphylococcus aureus. And I'll get into the sort of inclusion-exclusion criteria for the study shortly, and go into that in a bit more detail. And we're going to look at bacterial factors and compare them in the AMR infections with antibiotic-susceptible infections for these pathogens. And we're able to do that because in addition to all the clinical data that we'll be collecting from the hospital records, we're actually also collecting the bacterial isolates, and all of them will undergo whole genome sequencing in my lab, in addition to the standard phenotypic antibiotic susceptibility testing that will happen in the clinical labs. And then these strains that we're collecting, these isolates, will be stored, and we're going to be using them in an adjacent study to try and help develop novel vaccines and antimicrobials for these pathogens. And I'll also briefly touch on that as well. So the study participants are children aged 0 to 16 years with an invasive AMR infection, and I'll come on to exactly how we're defining that on the next slide, or any infection caused by these three organisms of interest, so Klebsiella, Streptococcus pneumoniae, and Staphylococcus aureus. And for invasive infections, we're really focused on bloodstream infections, meningitis, so isolates collected from the CSF, or other normally sterile sites, and not including the urine. And so this is the full list of the pathogens that we're interested in for the AMR group. So a group of gram-negative bacteria, and some of you may recognize your favorite organism on there, and the definitions of AMR based on current WHO definitions, as well as various gram-positive organisms, and again, the definition of AMR based on WHO definitions. So any of these organisms fulfilling these AMR criteria will be included in the study. In addition, the Klebsiella, Strep pneumo, and Staph aureus will be included whether they meet the AMR definitions or not. So the inclusion are a child aged 0 to 16 years on the date of arrival to the hospital, whether that's the admission date or date of the emergency department visit, invasive AMR infection based on their identification in the blood, CSF, or sterile site, or identification in one of these sites from any of these three priority organisms, whether they fulfill AMR criteria or not. We're excluding those cases where there's a positive growth of more than one organism in the same sample, where the infection is deemed not to be clinically relevant according to the medical care that they receive, and we're not part of the study is not to influence the medical care, so that will be at the discretion of the treating physician. And if the child is not admitted to hospital and only seen in other outpatient or ambulatory settings outside of the emergency department, they will also be excluded. Just briefly to talk about the network that we're using here called Popcorn. So this is a network across the 16 pediatric tertiary care hospitals in Canada, which includes expertise from emergency medicine, inpatient medicine, critical care, and infectious diseases, as well as some cross-cutting expertise in epidemiology, data governance, biobanking, and knowledge mobilization. And we've conducted a number of studies over the last few years. And then, as I mentioned, we're also going to be collecting bacterial isolates from all of these, and we're going to be using them in another consortium which I'm part of called Avenger, which is developing advanced LNP RNA vaccines to enhance pandemic readiness. And the goal of the Avenger project is to develop a lipid nanoparticle toolkit for vaccine applications, to engineer next-generation RNA vaccines using both self-amplifying RNA and other RNA innovations for effective low-dose vaccines, to develop an LNP RNA vaccine for an AMR pathogen. And those three pathogens that I've been talking about are the target pathogens for this work, which is why we're focusing on those in the popcorn study. And then to move on to biomanufacturing for a lead candidate and ultimately testing in a non-human primate challenge model. And so these projects really closely sort of mesh together to try and develop these vaccines for these pathogens. And then beyond that, we're hoping to address some of these questions. So what is the burden of AMR infections in children across Canada? So we don't have that data right now in Canada, identifying how bad the problem is. This will also enable us to have some baseline data prior to interventions, including vaccines, identifying the risk factors for disease and who we should target for these interventions in our context, and ideally helping to identify vaccine antigens that could be used and with a in the context of pandemic preparedness, a novel vaccine candidate that could be ready for clinical testing within 100 days, and then through the Canadian Immunization Research Network into phase 1 trials. This work also builds on a couple of other networks, including IMPACT, which is the Canadian Immunization Monitoring Program active, which also does surveillance of vaccine-preventable disease and other infectious diseases in children across the country in coordination by the Canadian Pediatric Society. So with that, I will end there. I just want to thank all of the participants and collaborators and funders of our work, my great study team here in Vancouver at the Vaccine Evaluation Centre, and there's my contact details if anyone wants to contact me for further information about this project or any of the other work that we're doing. And with that, Justin, I'll hand it back over to you for the Q&A.
Manish, thank you very much indeed. Very clear, and thank you for keeping to time. I've just had a look in the chat. There's a lot of people joining, and I know that Marvin's helping them with that. But in the meantime, I was wondering if I could put you on the spot and ask you one or two questions related to really more to the biology of some of the pathogens that you're looking at. Do you know? I've got two questions. Could you talk about the variability in Klebsiella epitopes and what this work will do for you and help you when designing what would be an amazingly important vaccine for neonatal sepsis, which I work in here at GARP?
Yeah, so that's a great question, Justin. So as you know, as you and others probably know, like Klebsiella pneumoniae is an extremely variable organism, and I think we'll have a number of challenges as we move forward to vaccine design. So there's a few current vaccines that are in early stages of clinical development based on the capsule or K antigen, and also the lipopolysaccharide LP also O antigen. So within those, the K antigen, there's over 100 different serotypes that are currently have been identified, and about a dozen or so LPS types that have been identified. And so, there is a lot of variability within those. And while there are some that seem to predominate in neonatal sepsis, I think it's still going to be a real challenge to identify a small enough number that could be feasible for a vaccine, sort of along the lines that we've seen with pneumococcal vaccines and other multivalent conjugate vaccines. So the other approach, which other groups are taking, is trying to identify conserved proteins, and we've seen this very successfully, for example, with the meningococcal group B vaccines. And so I think right now, probably the jury's out a little bit in terms of which of these is going to be successful in terms of having a vaccine with broad coverage against Klebsiella pneumoniae. But as you've sort of already alluded to, it's definitely a high priority for prevention of neonatal sepsis, and there's a lot of work ongoing in this area. Considering a vaccine for use in pregnancy, for example, to protect against neonatal sepsis, as well as work considering whether things like monoclonal antibodies for neonates, as we've seen for RSV, and also the other sort of big group right now that we're seeing with these infections are older children, adolescents, and adults with chronic diseases. But I think there's the concern that as AMR continues to grow across the world, that we'll start to see these infections more and more in otherwise healthy people as well.
Yes, Manish, thanks. That's very clear. And I think at SMID this week, there was very clear value for what you described there, the monoclonals with anti-RSV activity and really amazing real world evidence. So I certainly feel from our perspective that the work that you're doing in identifying and making vaccines is incredibly important. And we thank you for the good work that you're doing in this and for your time today. So I'm just going to warn Deborah that she's next. And thank Manish for an excellent, very clear and to time talk. And we'll move on to the next talk. Manish, thank you very much.
Thanks, Justin.
So our next talk is Deborah Tong. It is entitled Strengthening Global Stewardship Frameworks for Sepsis and AMR. And Deborah is an ID, an antimicrobial stewardship research pharmacist with an interest in low and middle income country research. And she is here in Geneva with me, although she's at the WHO and I'm at the GARD-P offices, where she is a technical officer at WHO in the AMR Health Systems Access and Data Division. And so, Deborah, welcome to the session, and we look forward to your talk. And I will be looking out for questions at the end from the chat, which I encourage people to add. Thank you very much.
Thank you very much, Justin, and thanks again for the flexibility in the schedule. Can you see and hear me okay? Great. All right. Thank you very much again for the invitation. Good morning, good afternoon, and good evening, everyone. I've been asked to do a brief intervention about global stewardship frameworks and how this might look for sepsis and AMR. So very briefly, I'll run through a very summarized version of the global AMR response, the stewardship guidance that WHO has, and a little bit about the AWARE system, which is a WHO global tool for stewardship, and how this might look for sepsis. I don't think I need to preach to the converted, but as we all know, there is a huge and rising burden of antimicrobial resistance globally. And in 2021, it was estimated that almost 8 million deaths were due to bacterial infections, with just under half of these associated with antimicrobial resistance, and around 1 million that were attributable or what we could say caused by AMR. And there is a significant proportion of sepsis deaths in particular that are attributable to AMR. So I think we are all speaking the same language here in wanting to get these numbers down and have the best care for our patients, including our sepsis patients. And this brings us to the global response, which was initiated around 10 or 11 years ago when the Global Action Plan on AMR was endorsed at the World Health Assembly in 2015. It has 5 strategic objectives, one of which is specifically looking at optimizing the use of antimicrobial medicines in both humans and animals. And as you may already know, the Global Action Plan on AMR is currently being updated and revised and is looking to be endorsed by member states later this year. The WHO in particular has what it calls its strategic and operational priorities to address drug-resistant bacterial infections for the next 10 years. And in brief, there are 4 key priorities that we are working on. And the first is to prevent infections in the first place so that we don't need to use as many antimicrobials. And this is through a number of infection prevention and control, water sanitation and hygiene, and vaccine interventions and initiatives. The second is around access to affordable quality diagnosis as well as treatment of infections through antimicrobials as well as other less traditional agents. The third priority is on strategic information, science and innovation, and building an evidence base. And this is mainly moving and strengthening the global antimicrobial resistance and use surveillance system so that we actually understand what the lay of the land is. And then the fourth is around having effective governance and financing and mainstreaming interventions into primary care where most of the antibiotics are actually being used. This slide is a little bit busy and I apologize for that, but essentially it is a summary of the commitments made by member states during the UN General Assembly high-level meeting on AMR, which was held towards the end of 2024. But what I wanted to really draw your attention to, and as may have already been mentioned earlier in the Congress, is that there is an important but ambitious target of reducing the deaths due to or relating to AMR by 10% by the year 2030. And this is something that member states committed to, together with the other target, which I've highlighted in the dashed box further down, which is relating to more of the stewardship aspect and appropriate use, and which countries agreed to striving to achieve to have at least 70% of antibiotic use globally to be from the access group. And I'll explain a little bit about what that means in the coming slides. I think also as well, we are considering, and WHO looks at and publishes some reports that analyzes the clinical pipeline of new antibiotics and other non-traditional agents that are coming through, being developed and close to or with the intention of coming to markets. And even though over the last years there's been an increase in the number of agents that are being developed that are active against critical priority and high priority pathogens, it is still insufficient to tackle the number of drug and the number and nature of drug-resistant infections that we are seeing. And so what this means is, while we are still, it's still really important to invest in R&D, we really must do more to preserve the effectiveness of the antibiotics that we do currently have. And that leads us to the WHO Aware System, which I mentioned before as a global antimicrobial stewardship tool. And it includes a number of key guidance areas, including the classification, the antibiotic book, indicators and targets, some implementation resources, and is also guided by the technical advisory group, which I'll speak a little bit about as well. You may have heard about the classification. It was developed since 2017 and basically categorizes the antibiotics that we have into 4 main groups, based on a traffic light system. And so similar to a traffic light, green means go, and these are the antibiotics that are classified as access, the ones that are usually narrower spectrum, have a lower potential to lead to resistance, and are usually the first line treatment for many common infections. And they include narrow spectrum penicillins like amoxicillin, benzopenicillin, flucloxacillin. And then we've got the watch group, which are the broader spectrum, usually more expensive, more toxic, and more able to, or have a higher resistance potential, and are usually kept as second line, except for some infections like sepsis, where you may need broader spectrum antibiotics to cover the most likely pathogens. And these are ones like the ones we see quite a lot being used, third generation cephalosporins like ceftriaxone, fluoroquinolones like ciprofloxacin, macrolides like azithromycin. And these are the ones where we really see the need for antimicrobial stewardship interventions to improve their use. And reserve, as the name suggests, the most broad spectrum, most expensive, the ones with the most side effects, which we really need to keep for last line treatment of infections caused by multi-drug resistant organisms. And these may include some of the newer beta-lactam, beta-lactamase inhibitor combinations like meropenem, valbobactam, or even some of the older agents which retain activity against carbapenem resistant organisms such as colistin. And then lastly, I'll just mention the not recommended, which is in the top right corner. This is a group we assign to antibiotic combinations, usually fixed dose combinations of multiple antibiotics or antimicrobials that are not supported by evidence. So sometimes we see in some parts of the world multiple penicillins being in one product, or an antifungal with an antibiotic. And these are not supported by good evidence, and WHO actively suggests to avoid using them. And we've got the book, which provides guidance on the management of most common infections that we see in primary care and hospital settings, and it's available in a number of different languages now. And I would just maybe draw your attention to, as I mentioned, it provides management guidance on lots of different common infections that we encounter in clinical practice, including in sepsis in neonates, children, and adults, with a new guideline currently being developed by WHO for clinical management of sepsis, mainly in adults. And there were some neonatal guidelines that were updated in 2024, and we are in the process of updating the book to align with these new WHO guidelines. And then I will just mention also we have a technical advisory group which is formed by with 24 members from the 6 regions of the world, and provides technical guidance to us to develop the AWARE system as a stewardship tool for use globally. We also have some access initiatives to make sure the antibiotics that should be at the patient's bedside are available. And you, Justin, will be very familiar with this, but we work with GuideP on the Secure initiative just to ensure and try to strengthen access to some key antibiotics, not just the new reserve ones, but also some access antibiotics such as nitrofurantoin, which many countries have challenges in securing access to. And also just to highlight that there are a number of regulatory initiatives that have been based on AWARE, and there are some links here, in particular to highlight that Nepal has used the AWARE system to implement a number of regulations and enforce them in order to improve antibiotic use in the country, with the drug regulator banning over 100 fixed dose combinations which fall under the not recommended category in the AWARE classification, and also more recently banning the sale of a number of reserve antibiotics outside of hospitals to try and control and restrict their use to patients who need them the most. And then lastly, I just wanted to end it on how we might see sepsis interacting with global antimicrobial stewardship and the AWARE system. And really, I quite often hear that there is a tension between sepsis management and antimicrobial stewardship, but both are aiming to really translate evidence into practice and to improve clinical outcomes of our patients. And they're two sides of the same coin. And while there is a need to balance the prompt management of suspected sepsis in our patients and avoiding antimicrobial overuse, we also need to make sure that essential antibiotics and antimicrobials for sepsis are available where they're needed and accessible as soon as possible and as soon as the diagnosis is being made. And we can see and starting to see the integration of aware and antimicrobial principles, antimicrobial stewardship principles into sepsis guidelines, pathways, tools, bundles, etc., to make sure that the right drug gets to the right patient at the right dose, is given for the right duration and de-escalated when and where appropriate. It's also important that we see the integration of sepsis management into stewardship policies and programs, and where we see stewardship being a part of patient safety and quality of care, we quite often then more easily can embed appropriate sepsis management into these programs as well. And just as the last point, to point out that we obviously need collaboration and knowledge sharing on a regular basis between those working in sepsis, those working in critical care areas like the ICU and emergency, together with those that work on antimicrobial stewardship in infectious diseases, not just our clinicians and physicians, but also pharmacy and nursing workforce as well. So I will end there. I'm not sure how I did with time, but thanks, Justin, and back to you.
Deborah, thank you very much, and delighted to have you to hear. Very quick question for me while Sie Meng is just getting ready for her next talk, just to flag that up. Could you talk? You talked a lot about some negative bans and stopping fixed. What kind of positive interventions have you seen that really work? Because I think you ended on collaboration. I think thinking about humans and how they operate, positive enforcement really works. And what's your evidence there? And that's really quite good for the people that are on the call today.
Sure. And I apologize if I was a bit strong on the negative side.
No. I thought you ended on that. And I wanted you to have a little bit of time to explore that.
For sure. And I think one of the key areas that we use in antimicrobial stewardship, both to improve sepsis care and other areas of clinical practice, is really this multidisciplinary approach and audit feedback and what we call handshake stewardship, if you like. And that might look different in different settings. If we were talking about sepsis particularly, many facilities implement some sort of intensive care rounds, for example, where the antimicrobial stewardship team consisting of physician, pharmacist, nurse, maybe someone from the lab would have regular interaction. Ideally, if it's face-to-face, that would be even better, where they may visit the intensive care unit 2 to 3 times per week and speak directly with the intensivist to discuss the patients that have sepsis and together discuss how best the antimicrobial therapy could be optimized for those patients in order to improve their outcomes and also avoid any overuse or broad spectrum use of antibiotics if that is the case. But quite often this helps to build that relationship and trust between the antimicrobial stewardship team and together with the intensivist. And over time, this really develops into something that is not considered, like a policing sort of initiative, but rather a partnership where you are both duly responsible for the patient's care.
Exactly. Carrot and stick and a handshake, and then obviously using alcohol gel after the handshake, of course. Deborah, thanks very much for making that effort to get across the Geneva traffic today. We really appreciate that. And we'll move on to our next speaker. So, Deborah, thank you very much. Sie Meng Lee, or Lee Sie Meng, as she should be called, is Let me just get my notes. At the International Federation of Medical Students Association. So welcome today. She's actually a medical doctor from the Netherlands, and she is one of our young leaders. And I think this is brilliant that we've got someone like that today. Fosters meaningful youth participation, because all of these things need to start when you're younger, so they're embedded in global health diplomacy. And she's been coordinator of the Dutch WHO Youth Delegation Program at the Youth Pre-WHA that we heard about earlier on today. And she's going to talk about neonatal and pediatric sepsis with an emphasis on microbiological insights, diagnostic innovations, and of course the AMR challenges. Thank you, Sie Meng.
Thank you so much, and thank you also for the invite to have me in this part of this congress. Yes, and as you said, I will be talking about pediatric and neonatal sepsis, and I want to say that I am not an expert in this field, of course, as a young medical doctor, but I would like to address it from a medical student or young doctor perspective to show the challenges that we see here, even and not being an expert. I'll start my presentation. Okay, I hope you can see my screen. Is it working? Yes, perfect. Okay, so as briefly mentioned already, I am part of the International Federation of Medical Students Association. We are an organization for medical students all around the world, working mostly on global health, also empowering young medical students to be health leaders now, but also for the future. And we organize several activities all around the world to do so. So our organization is made up out of over 1.5 million medical students worldwide, organized in over 130 organizations around the world in different countries. One of our biggest projects that we do is organizing student exchanges, where we have over 15,000 students go on an international exchange every year to also get to know other health systems. And we are organized in 5 regions across the world: in the Americas region, Africa region, Europe, the Eastern Mediterranean, and the Asia Pacific. And this regional division allows our students to also get familiarized with students that live closer to them rather than on the other side of the world as well. And our work that we do is structured according to 6 standing committees. So we have a group of students that focuses on improving medical education, the two exchange standing committees focusing on clinical and research exchange, and a group that works on sexual and reproductive health and rights, including HIV and AIDS, as well as a group that works on public health and human rights and peace. So as we mentioned before, one of the big projects that we organize is the student exchange program, where we have 4 or 8 weeks research exchanges or clinical exchanges. And we also organize other meetings where medical students around the world can meet. Our general assemblies twice a year, but also regional meetings, and the UP World Health Assembly, which is taking place always right before the World Health Assembly, where we also prepare our young leaders to also advocate effectively for global health issues in the World Health Assembly. So then coming to the topic of sepsis and AMR, mostly as medical students, the first encounter with sepsis is mostly in a very hectic setting, when on a patient alarm, when a patient is already deteriorating. And I think I would like to come to the main point of my small talk here today already, is that preparedness, early recognition, and timely teaching in medical schools is essential. Especially when we focus on neonatal care, it's harder to recognize a deterioration of patients, which is why recognition before we get to the stage of sepsis is important. And I think the point is that if we only learn from a clinical context, we risk that we have a generation of young doctors and medical professionals that only recognize it when it's already in a stage where it's hard to overcome. And I think also what I would like to touch upon is that sepsis and AMR are often spoken of as big crisis for the health system, but often not addressed together. Rather, when it's very clear that these two problems are like a continuum of one of a shared problem. Sepsis is the outcome of an infection, whilst AMR also determines the success of the treatments that we start. So if we have antimicrobials fail due to resistance, it is harder to avoid sepsis, harder to treat, will progress faster, and will also have more mortality associated with it. And I think also in specific in pediatric populations, it is a leading cause of childhood mortality, and I think that is caused by a cascade of issues. So looking at the fact that young children have higher vulnerability to infections, while the disease also progresses more rapidly with sometimes a very non-specific clinical presentations that is also atypical for sepsis. And this rapid progression also leaves us with a very small window for intervention, which is why, once again, I believe the timely recognition before we get to the stage of sepsis is key. Touching upon like the challenges in with regards to microbiology in pediatric sepsis, is that we often rely on empirical treatment rather than having access to the actual pathogen that is causing the disease. And this empirical treatment also causes increasing antimicrobial resistance. Another thing is that we also see huge variations in pathogen profiles across contexts, and this all collectively causes us to make treatment decisions without very precise and targeted guidance. I think also, once again, like coming to the diagnostic challenges here, these are also overlapping a bit with what I said before. Sometimes we do not even, when we want to have access to the microbiological testing, the results might be delayed and the disease might be progressing faster than the test results are there. And also here, it is hard to distinguish the severity of the disease in early stage. And there's been a lot of progress in the field of diagnostics, but also at the same time, the access to these in different contexts is still unequal. And to different contexts, like for high resource settings, we see different problems than compared to low resource settings. In high-income countries, we often see overuse of antibiotics, very defensive prescribing. And there, the challenge mostly that we see is the balance of rapid treatment compared to antibiotic stewardship. Whilst in low resource settings, we are facing more challenges of limited diagnostics or limited access to effective antimicrobials, late stage patient presentations, and gaps in infection prevention and control, as well as an early prevention mechanism. So I think in that sense, AMR reflects also a lot of like the constraints that the health system presents, not just the issues that are associated with the pathogens. So looking at when we do not have the necessary diagnostics, we fall back on using empirical therapy. And at the same time, we also, if we don't have a sufficient infection prevention control or diagnostics, it is hard to avoid the cascade of sepsis, infection, and AMR. I think from a medical student perspective, like it's very clear that we see those system gaps everywhere around the world. For example, if we have inadequate water sanitation and hygiene measures, the infection risk increases. Once again, limited access to diagnostics delays targeted therapy for infections. If we have issues with the supply chains and the supply of antimicrobials, that will also limit access. The facilities and the limits of our healthcare institution also accelerate the spread of antimicrobial resistance. And I think like as long as we do not address those gaps in the health system, we cannot avoid the spread of diseases and the continuous rise in antimicrobial resistance, and also avoid sepsis in an early stage. And I think that impact is particularly seen also in neonatal pediatric care, as we said, as children and neonates are way more vulnerable to infections. From a medical student perspective, once again, I do think that there is a huge wins to be made. Students are always present on wards, closely observing patients for their learning, challenged to ask questions, also tasked with doing basic tasks like taking vital signs. And in that sense, if we adjust medical training, they can be one of the first line responders in noticing subtle deterioration before sepsis even occurs. And I think properly preparing medical students now is both an investment in the present as well as in the future. And I think I will come to the close of the end of my short intervention. We need several changes, both in the clinical culture, but also in medical education. And I think that is coming to strengthening more infection prevention and control, to have context-specific antimicrobial stewardship, to also teach early recognition that is adapted to a local context, and also to teach medical professionals to make decisions under uncertainty. For example, when we do not have diagnostic evidence, to focus specifically on one pathogen in our treatment. And I think what can medical students do in that, and what are we already doing, is a very diverse set of actions. We can organize awareness campaigns regarding AMR and sepsis and foster peer education. We engage in advocacy for infection prevention and safe care, engaging communities and organizing activities to also increase that knowledge. Our exchanges will also help place students in emergency intensive care settings, and also recognize and get to know different health systems and their limits. Transfer knowledge across different resource settings as well. In that, for example, the research program, research and exchange program. And lastly, also to hold our systems accountable for sustainable AMR financing as a whole, to allow that more research to be done and developments to be made. So that is, from my side, our short contribution to this program. If there's any questions, feel free to contact me, and I'm sure Justin might already have some questions as well. Thank you.
Sie Meng, thank you very much. Again, thanks for finishing on time, which allows us just a couple of minutes for questions. It's interesting, isn't it, that sepsis often will present to different departments. So therefore, medical students have different opportunities. They might see biliary sepsis at the time of working on a general surgical team, but they might see internal medicine with other presentations. Are you aware of across different medical schools how antimicrobial stewardship is actually taught within the curriculum? Do you have any information or evidence about how well that's covered across different medical schools?
I think it's a very good question. If we come to the preparing the health workforce on AMR issues, right now I do not have any collection of data regarding AMR education across countries as a whole. I can speak from my own perspective as a medical student from the Netherlands, which is just a small part. I know that antimicrobial resistance and preventing it is a very big priority within our health system. And I also know that in that sense, antimicrobial prescribing in the Netherlands is really, really limited. And that is also already something that is mentioned has been mentioned quite a lot in my medical program. So as doctors, that we can prevent AMR by prescribing and prescribing responsibly, and in that sense, not being too defensive about our prescribing, and also being targeted in what we do. And I think that sense, in my medical program has been covered very well, but it has stayed limited to that, just only that. And I think we could do more in, as if I speak to my own national context, we could also do more in creating awareness about AMR amongst the general public, because so oftentimes do I still hear about, oh, I'm feeling so sick, should I not just get antibiotics? While we know that the prior chance of it being a viral infection is so much higher. And I think that is something that is where we can still gain a lot.
Brilliant. Thank you very much for your time today. And we're going to move on to the next talk. So I really appreciate your energy and effort. So our next talk is Ivalda Macicame from Mozambique. Ivalda is an epidemiologist by training. She's actually the director of surveys and health observation at the Instituto Nacional de Saúde in Mozambique. And she is a big contributor to the COMSA platform, the Countrywide Mortality Surveillance for Action. And Ivalda's talk today is Challenges and Prospects to AMR Stewardship in Resource Limited Settings. So really nicely follows on from what we heard there in the Netherlands. So Ivalda, over to you.
Hello, everyone. Thank you, Justin. And I would like to also say thank you to the organizers for the invitation to talk about challenges and prospects to antimicrobial stewardship in resource-limited settings, one of them where I live. So when we are looking at the global map, we can definitely see the high burden of sepsis mortality in Africa and Southeast Asia. And those are the same exact places where we do have a higher percentage of AMR and low AMR surveillance. And those are exactly the same places that according to some modeling, by 2015, they will still be the places or the regions with the highest antimicrobial resistance and antimicrobial resistance mortality. So it's urgent to act now in order to prevent these chaos in places where resources are already limited. When we are talking about antimicrobial stewardship, I would like everyone to be aware of those key words: coordination, integration, and optimization. And I will talk about challenges of antimicrobial stewardship based on those 5 WHO pillars of AMS integrated activities. So going to the first pillar, that is coordination, that is already on the definition on antimicrobial stewardship. Most countries already acknowledge the fact that it's important to have guidelines in place. And one of the guidelines that is being implemented, but before that being developed by many resource-limited settings, is the National Action Plan on Antimicrobial Resistance. And Mozambique and many other African countries already have those NAPs. But having them is one thing, implementing is another thing. And we can take a look at this global map where it is clear that in most African countries, in some South Asia countries, there is no still formal multisectorial collaboration or coordination with that is one pillar of the NAP plans is having this One Health approach. And this can also be seen in some publications. And this one shows some African countries, 5 African countries, including Mozambique, where it is clear that there is no fully functional AMS programs in those countries. And we can see different approaches, different assessments when we're looking at having AMS committees, having the leadership commitment to improve or to implement AMS programs. Going to the second pillar, that is ensuring access and regulation to antimicrobials, we are talking about countries that already have very low universal health coverage. So this includes not having sometimes access to health facility, and having access to health facility, this might include not having appropriate quality of care. And this has influence on the way that people access to antibiotics. And we can see in this paper that there's a need to make sure that we look at the other options that the communities have apart from health facilities to have access to antibiotics, such as private pharmacies or even informal drug procurers has integrated into the solution for antibiotic misuse and overuse, and not looking them as only the problem. And still looking at access to antibiotics or antimicrobials, even for those that have access to antibiotics, even those that can go to a health facility, most of the times the health facilities do not have the appropriate prescription practices. And Deborah was talking about the WHO AWARE program, and this paper is from Mozambique, in a city called Nampula, where it was concluded that there was an excessive and inappropriate prescription of antibiotics, and those prescription is not based on the WHO AWARE recommendation. And this might be a reality for many other places in Mozambique and in Africa and Asia. Going to the third pillar, that is awareness, education, and training. There are already papers that shows that in low and middle income countries, there are huge prevalence of non-prescribed antibiotics. And the source of antibiotics is vague, it's abundant. People can have access at the pharmacies, at the communities, even at home, those drugs that were prescribed before. And there's a lot of perceptions and cultural practices around utilization of non-prescribed antibiotics. And this is also has to do with the non-optimal or suboptimal levels of knowledge, attitudes, and practices regarding antibiotic use. And these are some of the papers from different places in Africa, one from Mozambique, one from Lusaka, Zambia, some from Malawi, Rwanda, that shows that there are low knowledge, attitudes, and practices from the community level to the pharmacy professionals, and even at the farmers when we're looking at the One Health approach. Going to the fourth pillar, that is WASH. This map shows that in the majority of African countries, less than 50% of the population, in some countries less than 25% of the population have basic hand washing facilities and water at home. So this is a huge challenge for African countries. And when we are looking at IPC in health facility, we could see during the COVID pandemic that having access to IPC in some African countries was a huge challenge, but we could also took the opportunity to look at the barriers and facilitators to the healthcare, to the health workers' adherence to IPC, and actually increase the awareness of IPC at the health facility and at the community in general. This was one of the gains for during the COVID pandemic. Going to the final pillar, there is surveillance, monitoring, and evaluation. There are countries that are trying to improve AMR surveillance, and also trying to improve gathering of information on sepsis itself. but we still have a long way to go. This graph shows that, for example, for African region, we have more countries reporting to GLAS, but we are still under 60% of countries all over Africa that are reporting to GLAS. At the end, I would like to talk about the good things. We can take a lot of opportunities when we're talking about antimicrobial stewardship in resource-limited settings through coordination at all levels, from the global level to the national level and to the local level. We do have we gain a lot of experiences when writing and trying to implement the national action plans for MRI, for Run Health, even the global health security agenda also supports this coordination globally. And we also can leverage, although we are in a very complex moment when we're talking about funding, leveraging the opportunity of global funding for epidemic preparedness and response could be a way to go in resource-limited settings, given that the majority of the conditions that we are talking about are infections that leads to sepsis and leads to AMR. And when we are talking about the global, let's say, climate change, we have a lot of cyclones, especially in Mozambique, and there's a lot of trauma that also leads to sepsis. We can try to leverage those kind of funding and having coordinated resource sharing. And leveraging COVID gains, as I mentioned, during the COVID, we were able to improve laboratory capacity in low resource-limited settings. We improved IPC awareness, as I mentioned before, and we have a lot of experience when you're talking about vaccination or immunization campaigns. We do have the advantage, at least in Mozambique, and I'm sure it's the same in many African countries, where vaccination acceptability is still high. So we need to take advantage of that in order to prevent infectious diseases in country. And yesterday, Professor Corrid mentioned STAIRS, and we are very excited about this beautiful project that is being funded and supported by German government, where we can elevate quality of research in sub-Saharan Africa. When we're talking about sepsis and AMR, we are able to strengthen capacity for sepsis research and care, which includes AMR. We are increasing the networking inside our countries and also abroad. And policy engagement and research transfer is a huge component of this project, which will definitely increase evidence-based policy decision-making and also increase awareness at all levels. So this is what I had to share with all of you. Thank you very much for the opportunity again.
Ivalda, sorry, frog in my throat. Ivalda, many thanks. And that's actually given us a couple of minutes for questions before we move over to Sheila, who's joined us live. So I'm going to put you on the spot. I hope this is an open question for you, but I saw Mark Mendelssohn's paper there on over-the-counter antibiotics. We're talking about interventions. In the context of over-the-counter antibiotics, do you know of any interventions that are working in a kind of positive sense, working with pharmacists? Because sometimes maybe they might have some kind of financial incentive to prescribe or ensure that an individual buys an antibiotic. So what can we do in the context of over-the-counter antibiotics to try and ensure that kind of balance is seen and that we can work positively with our pharmacists in the community?
Thank you for your question, Justin. Well, when I will be talking about Mozambique, where I have more knowledge. We still have in rural areas, not much pharmacists. So we need to work with community workers. So I think this is where we need to look at when we are talking about antibiotic use and availability, because those are community workers that have access to some medication, and we need to make sure that they have the knowledge, the level of knowledge needed to not to prescribe, but to make sure that they don't give antibiotics at the communities they are working without prescription. I think this is the first level. And in places like Mozambique, about 60% of the community still don't have access to health facilities. So they really have to rely on these community workers. When we go to more urban or peri-urban areas, this is where the access to health facility increases, and we have more people going to the health facilities. But though, even with the access to health facilities, those people sometimes they prefer to go directly to the pharmacist. So you're right, we need to make sure that the pharmacists do work together with the health sector and the One Health in general, in order to make sure that they have a huge impact on reducing AMR. I'm not aware of any initiative, at least in Mozambique, where there are incentive-related interventions, but definitely there's a huge increase on regulation when we're talking about AMR prescription and in Mozambique, and there's more collaboration. There are pharmacist associations in Mozambique, and they are a huge part of the decision making when we're talking about regulations and norms in the country. So I think it's a way to go. I think at some point we'll get to the incentives and have more interventions on the pharmacists. Thank you.
Ivalda, many thanks for your talk today. Very clear, and thanks for taking my challenging questions. And we're going to move on now to Sheila Myatra. Sheila is a professor of critical care medicine at Tata Memorial Hospital in Mumbai, India. She has an impressive CV, which I'm not going to read out, Sheila, but I know that you have been very influential in the context of critical care medicine. And you're going to talk to us today on gaps and strategies for adult sepsis management in low resource settings with a global expert consensus. So many thanks for joining us live today, Sheila. We appreciate that effort.
Thank you, Justin, for that kind introduction. Hello, everyone. I bring you greetings from the Tata Memorial Hospital, India, where I work. I have no relevant disclosures for this presentation. I'm going to be speaking about the gaps and strategies for management of sepsis in low-resource settings from a recent Delphi that we published in Critical Care Medicine, and this was convened for the Society of Critical Care Medicine. And I really urge you to read this paper because I will not be able to cover all aspects in the next 10 minutes, but I will at least give you a broad overview and you could read the paper later. So just to contextualize this, when we talk about sepsis in low resource settings, and we know from the Lancet paper that there was an estimated 49 million cases, 11 million deaths worldwide in 2017. And as we know, more than 80% of these cases occur in low resource settings. And when we talk about low resource settings, we're not just talking about low income countries or some geographical locations. We are talking about any setting in the world where there's limited access to trained staff, infrastructure, diagnostics, medications. And the World Health Assembly Resolution 70.7 emphasizes the improvement of diagnosis and management of sepsis and calls for improved sepsis care using a multi-sectoral approach. Now, when we look at the specific challenges in sepsis management, we have great guidelines, and we have the last iteration of the Surviving Sepsis Campaign guidelines. However, they face limitations, implementation limitations due to infrastructure, personnel, and diagnostic limitations in low-resource settings. In addition to this, distinct strategies are required to manage diverse social determinants of health. tropical infections, antimicrobial resistance that the previous speaker just talked about, comorbidities and population characteristics, limited ICU availability. And we know most of the sepsis is not managed in the intensive care unit, but a lot of it is managed in the general wards. And there's limited guidance on how we should manage sepsis outside the intensive care unit. And to address these challenges, the sepsis chain of survival was developed, and this was also published in Critical Care Medicine. And this chain of survival consists of 6 critical interlinked chains, which are for the management of sepsis in low resource settings, right from awareness, early recognition, continuous source control, appropriate fluid, oxygen, and antibiotic therapy, critical and intensive care without walls, and post-sepsis care. So what we did is we used Delphi consensus to generate among experts using this chain of survival as a framework. And the goal was not to form another guideline, but to complement the existing surviving sepsis campaign guidelines. And we tried to identify the gaps and provide additional guidance wherever there were barriers for effective management of sepsis in low resource settings. So this was a panel of 24 members, and this was convened by the Society of Critical Care Medicine. We had 20 experts, and they were multi-professional, and we had criteria for including them, and they had to have clinical expertise in sepsis, prior ongoing experience of working in low-resource settings, research, education, or other relevant professional activities related to sepsis in low-resource settings. And we had a Delphi survey focus groups, and this was made of 7 members, and they did not participate in the iterative rounds, but they formed the surveys, and we had separate panelists who performed the voting. So there was an extensive literature search we did starting from 2000, but there was limited evidence for the management of sepsis in low resource setting. And this is the reason why grade methodology was not used. And then the next best thing is to use expert consensus using a Delphi process to provide guidance. And that is what we did. And the Delphi survey focus group, what they made was we made the domains and the statements, and the panelists was another group, and they were part of the multiple iterative rounds. And the questions that were part of this were both multiple choice questions as well as Likert scale questions. And in each round, they had the provision for providing feedback, and the responses were anonymized to avoid any group bias or group pressure. And then the survey was further refined, and the report was presented to the panelists in the next iterative rounds. And we use 80% as agreement for the questions, both the multiple choice and Likert scale. And the Delphi results were reported using the ACOID guidelines. And from using this, we identified key gaps and expert clinical practice statement. And these are the following 10 domains that we addressed. And this fits within the framework of the sepsis chain of survival. So it took us 8 rounds to get consensus, but we had 92% of the panelists completed the survey, and we had 94% consensus. And they agreed that additional guidance is required for sepsis management in low-resource settings. And the key barriers that were identified were limited access to care, resource constraints, socioeconomic barriers, limitations of trained healthcare workers, and late or miss recognition. And in addition to this, there was also consensus for unique population characteristics that must be considered while managing sepsis in low resource settings. And these include various demographics, the population, the social and environmental factors, also the underlying comorbidities, and healthcare seeking behavior and access, including vaccination, health literacy, and other factors, and also varying sepsis etiologies, like the tropical infections, malaria, tuberculosis, etc. So I'll just go through quickly on the various gaps that we identified and the consensus that was generated. So regarding sepsis awareness and prevention, the panel, there was consensus that the current methods that are available for prevention, excuse me, and diagnosis of sepsis are inadequate. And the commonly used scores may not be predictive of sepsis. And the common barriers for prevention of sepsis included lack of awareness, limited vaccination availability, malnutrition, inadequate sanitation, and other factors. And in addition to this, the hospital-acquired infections remain very high in the low-resource setting. And the clinical practice statements for which we had consensus was to improve awareness through various means, healthcare visits, available media, community engagement programs, including community visits and the use of local facilitators, And HAIs, considering that they were high, various measures to help, including implementation of the bundles promoting hand hygiene. WHO also has a campaign for safe hands, save lives, and implementing this in these regions. Regarding early recognition and call for help, the barriers to implementation was clearly limited awareness in the community, inadequate diagnostic tools, and of course, delays in lab results. And the other barriers, including lack of awareness, were socioeconomic factors, financial constraints, and limited access to clinical care resources. So some of the consensus that we had, the clinical practice statements, were related to improving awareness and training community excuse me, to recognize sepsis promptly, and also training the EMS first responders to recognize and manage sepsis. Now, one of the things is when people transfer to a higher facility, one should consider the risks and benefits of this transfer. And a lot of times, patients are transferred without any initial management. So there was consensus that one should look at appropriate respiratory support. At least you have IV access, administer the initial dose of antibiotics, initial fluid resuscitation, and having a healthcare worker trained in resuscitation to accompany the patient, if feasible, with basic resuscitation equipment. And having a proper handoff when the patient was transferred to the facility. And in addition to this, in the absence of diagnostic tools, simple interventions, clinical assessment, fever, tachypnea, altered mental status could be used, even capillary refill time, low urine output, and IMCI danger signs could be used for making a probable diagnosis of sepsis. Source control is really important, as we know, for sepsis, and the main challenge encountered was achieving effective source control due to the delays in identifying the source of sepsis, and also facilities having inadequate surgical infrastructure. And the consensus was that in settings where access to needed surgical care is limited, surgical task sharing can be done by non-specialists. And in addition to that, one could also transfer to a facility with required surgical capability whenever this is feasible. Appropriate fluid, oxygen, and antibiotics, and this is the mainstay of the therapy in patients with sepsis. And it was very clear that the key gaps are the resources are insufficient, and many of the protocols that are available are not appropriate for, need to be adapted for low resource settings. Late presentation, inadequate staffing, and limited critical care resources was also another challenge. And in addition to this, delays in the diagnosis, inadequate knowledge, and also appropriate knowledge about appropriate antimicrobial therapy, not just the availability, but also the high cost and the burden of antimicrobial resistance. And the clinical practice statements related to this was protocols for oxygen therapy, and also using simple signs, for fluid resuscitation, to guide fluid resuscitation, heart rate, blood pressure, capillary refill time, even changes in oxygen saturation, and recognizing that there may be a high load of parasitic infections, also empirical use of antiparasitic agents, and clinical improvement alone, especially when there were delays in getting the lab tests for cessation of antimicrobial therapy to prevent indiscriminate use of the therapy, and also recognizing that there's limited availability of ventilators, assessing fluid responsiveness using simple tests, using whenever there's requirement for balanced salt solution when it's indicated, non-proprietary solutions like Ringer's lactate and Hartmann solution could be used. Albumin is also expensive, so specific indications when there's high volume resuscitation is there, and then is required, and the patient's still hypotensive, albumin may be considered. The Surviving Sepsis campaign already talks about use of epinephrine as an alternative when norepinephrine and vasopressin is not available. But in addition to this, vasopressors could be continued through a peripheral venous line in case central venous access was not available, or the expertise to use it, put a central line is not available. And also, if there is no lab facilities immediately available to rule out non-infectious causes of acute illness of sepsis, then antimicrobials should be administered without any delay. The other important gap that was identified was critical care without walls. As we mentioned, most of the sepsis is managed outside the intensive care unit, and other challenges of early mobility because of lack of awareness, but also because of unavailability of adequate staff. So the clinical practice statements related to this is that when patients are managed outside the intensive care unit, there should at least be a consultation with a critical care specialist, either via phone or telemedicine. There should be clear triggers for escalation of care, and a patient, we identified what is the minimum monitoring that is required, and also the minimum investigations that are listed here. and what are the triggers for escalation when a patient is managed outside the ward, and whenever possible, early mobilization should be conducted, and telemedicine should be used whenever it is feasible. And the last part on post-sepsis care and return to the community. Now, this is a unique challenge because, once the patient leaves the hospital, then there's insufficient follow-up, and transportation challenges prevent follow-up and lack of coordinated care. So the consensus was to formulate a comprehensive discharge plan, including signs and symptoms and, what the patients should look out for, and also risk assessment and identifying high groups that should present back to the hospital, and there should be follow-up, also community-based rehabilitation programs, and increase in family engagement. Now, future research priorities, it was clearly identified that financial constraints and inadequate research infrastructure were the biggest barriers. And the panelists emphasized the importance of research focus on early detection and diagnostics. And the key priorities for future research were raising community awareness, enhancing prevention strategies, training programs, developing affordable diagnostics, and affordable resuscitation methods. And of course, future research is required to assess the feasibility of these statements that they've made and also address the remaining uncertainties. So the strengths were clearly that it was a multi-professional expert group, and they addressed the key gaps using the sepsis chain of survival through a robust Delphi consensus. But of course, these are expert opinions, and they may have been influenced by the local resource constraints of the panelists, and there were several relevant gaps or guidance that may not have been captured. And there may be also superior interventions for the same. So in conclusion, I'll say that we used, a robust Delphi method to get consensus on 58 statements, and from which we formulated 24 clinical practice statements. And these statements address areas with limited evidence and through the sepsis chain of survival. And I would look at this, that these serve as a gap between the current needs and future research. And these complement the current surviving sepsis campaign guidelines for management of low resource settings. And of course, future research is needed to assess the effects of these strategies. I leave you with this paper, and I really urge you to read it. And I thank all the panelists who helped in formulating these consensus statements. And with that, I thank you very much for your attention.
Professor Myatra, what a brilliant summary of what must have been an enormous effort in this Delphi process. So many thanks, and thanks for putting the reference at the end there, which I really encourage our people watching today to go away and read in a moment, because there's so much important information there for the kind of settings that we were really trying to focus on in this session. So we are coming to the end of our AMR and sepsis strategies in different resource contexts. I'd like to thank all of our 5 speakers today and close the session at this point, reminding you to come back at the top of the hour. That will be 10 a.m. in Berlin, where Marvin is hosting, and here in Geneva. I suspect that's not the time in India. Professor Myatra, we thank you for coming later in your day for a really clear presentation, and a big thanks to all of our speakers for keeping to time and allowing us questions. So we will finish the session there. So thank you ever so much, everybody.
Thank you.